had the opportunity to discuss induction therapies based on risk in the newly diagnosed multiple myeloma setting. It was a great session, and basically we got the opportunity to review what it means to have high-risk disease and what high-risk disease looks like in 2019. That includes things like cytogenetic abnormalities and up-and-coming strategies for further defining risk in our patient population, as well as the incorporation of non-genetic factors like frailty and comorbidities, and how that determines our overall survival and the outcome for our patients. So moving on from there, we got to discuss what optimal therapy would look like. MRD is becoming an increasing endpoint in our studies because these patients are having improved overall survival when they achieve MRD negativity. So whether or not that is a true surrogate endpoint or not remains to be seen, and has some challenges remaining in terms of how we best study or analyze MRD and what it means for our patients. But I think it's an exciting emerging endpoint that allows us to start to examine the induction drugs that we have and what induction regimen might be best. So we have multiple triplet combinations. Now we believe that triplet therapies are standard of care for all patients, even the transplant ineligible, when they're able to tolerate triplet induction regimens. So that is the standard recommendation, but picking the best triplet combination remains to be seen. Usually it's a proteasome inhibitor with an immunomodulator and a steroid, but as we have these monoclonal antibodies that have arisen, the question remains whether or not we should be incorporating these, and if we're moving towards more quadruplet induction regimens. It's too early to say that now, but a lot of the work being done here and presented here this year at ASCO is allowing us to start to ask these questions, and it's just going to take some time before we know truly the best outcomes. We also talked a little bit about transplant, with the role of transplant in the current disease setting, and that in general we still recommend transplant for upfront patients who are eligible. And then maintenance is also recommended, but that's really where we have more data on where we should risk stratify, given that some of our standard induction regimens like lenalidomide that have been compared to placebo don't seem to have the same benefit in our high-risk patient populations, which highlights the need to do more for those patients, likely adding a proteasome inhibitor in combination. So that's what we talked about, and it was a great opportunity, and we had some good discussion. I think that some of what is going on and what's being presented here at this meeting is, we're starting to redefine when myeloma begins, or can we work to prevent myeloma in their smoldering setting? So there's data being presented on further risk stratification, so better identifying those smoldering myeloma patients who are eventually going to develop symptoms of myeloma, and can we intervene earlier to prevent that from happening, or should we treat earlier to control their disease for a longer period of time? And some other interesting data is being presented on the role of transplant. The Forte trial looked at patients who had been randomized to different induction regimens, including carfilzomib-based induction with lenalidomide versus cyclophosphamide. And at ASCO this year, they're presenting data on the two carfilzomib lenalidomide arms, one with transplant, one without, that seems to demonstrate that transplant continues to have at least a longer-term progression-free survival for our high-risk patients.